So now next started in number 4 factor, basically what it is. So it is genetic factor actually. Genes are sometimes like P53, like these genes can be involved that basically, okay, the overexpression of these genes can cause lichen planus, then infections basically it may be bacterial, okay. It is not basically confirmed, but spirochetes and road like have been detected actually, okay. Now habits, then you have like chewing tobacco, petal chewing increase the prevalence. Even the smoking like tobacco and petal chewing and smoke, they play a role in and can initiate or oral lichen planus of the plaque type, okay. Nutrition, you have like vitamin B1 deficiency, B6 deficiency and vitamin C deficiency. You have vitamin B1 and vitamin B6, vitamin C and electropotential difference also. Now moving to psychogenic factors, like you have stress or neurogenic basis is suggested. Then number most important, the syndromes which are associated with lichen planus. So always remember there are three things. Number one, grain span syndrome and Graham Little syndrome. So in grand span syndrome, this is diabetes mellitus, like oral lichen planus, okay, and vascular hypertension. So you have studied about two types of hypertension, number like the primary and secondary. The primary has no underlying cause, but the secondary has underlying cause that you can detect it actually, which you can be in genetic or diet, etc., what you can say. But D, L, and we remember it is for diabetes, oral lichen planus and vascular hypertension. Graham-Little syndrome is basically alopecia, nail changes. Always remember this is actually mucocutaneous oral lichen planus, you can say. Then HIV infection may be also contribute to, okay. So grain span syndrome, Graham-Little syndrome and HIV infection. Now moving towards how the patient is. Always remember bilateral, very important. Both the sides of oral mucosa is involved in 90% of patient. Tongue can also be involved. Cystic is again bilateral, white streaks on the buccal mucosa, which is vacuum stripe. In your viva, in your histopath, even in your competitive exams, there's a very clear actually cystic or sign that this is vacuum stripe. Reticular form tends to be asymptomatic. The reticular form is asymptomatic, okay. In other forms, you have erosive epithelial layers are separated and easily lost when, which results in ulcerative lesions. Means this can be also ulcerate when these lesions are lost. Okay. So what you have studied bilaterally, it involves the oral mucosa. You have bilateral YC, which is vacuum striae, and you have reticular, which is asymptomatic erosive epithelial you can have. Then you have also ulcerative lesions can also be occur because of this. Now, what is the most differential diagnosis? You have leukoplakia, then you have candidiasis, you can say, or chronic ulcerative stomatitis, pemphigoid, pemphigus, etc. It's your like 4 to 5 you can write it actually. Okay, now moving towards the diagnosis. The diagnosis is basically on the clinical presentation, how the patient represents to you. Then it is histopathological examination again and direct immunofluorescence. Okay, so you diagnosis on three bases: clinical, histopath, and immunofluorescence. Okay. Now there are treatments. So basically you can have a mouthwash which is antiseptic like chlorhexidine mouthwash. Analgesics, you have benzardamine hydrochloride mouthwash, legokinine rinse, okay. So chlorhexidine antiseptic mouthwash, and analgesics you have benzardamine hydrochloride mouthwash, and then lendocaine, or you can say it is legnocaine, okay. In antifungal, remember these three drugs very commonly given: nystatin, amphotericin lozenges, okay, and muconazole gel you can give to lichen planus patient, okay, very important point. And fluconazole also. So remember this is basically A N M M and F, okay. amphotericin, nystatin, mucoconazole gel, and fluconazole. Now moving towards some topical treatment which we give to the patient in initial stages. You have triamcinolone, acetinoid, yeah, log in aura base, which is 10 days, and you have to put 4 times a day. QID, okay. uh, triamcinolone or canalog, you can give it. Then you have fluocinolone, acetinoid, fluocinolone or triamcinolone, and fluocinolone, okay. Then you can give it basically colobetasol propionate, okay. Colobetasol can also be given to the patient actually, cola-betasol and propionate. Then you have betamethasone sodium phosphate. This is mouthwash, ठीक है. Betamethasone sodium phosphate, beta, okay. Beclomethasone, you have beta methasone, you can learn it like beclomethasone and dipropionate, ठीक है. So this is dipropionate. The above was propionate. This is dipropionate. Then topical tacrolimus. Tacrolimus 0.5% ornament. Ornament which you use it is tacrolimus. Tacrolimus you can give intralesional injection. It is triamcinolone, very important. So what you have learned? Triamcinolone. You have then learned fluocinolone, then colobetasol, propionate, betamethasone, sodium phosphate, then beclomethasone and dipropionate. Then you have tacrolimus. Tacrolimus 0.5% ornament. So it is tacrolimus, an injection like triamcinolone. Then in systematic treatment, you give to the patient corticosteroids, very important. Prednisolone, which is 20 to 40 milligram per day, you will give for 2 to 3 weeks. Then taper them slowly. In immunocompromised, you have two drugs, which is azathioprine and cyclosporine. So basically what is this? Azathioprine is given 50 to 100 milligram per day actually, and cyclosporine, which is 3 to 4 milligram per kg per day, you given. In other drugs you have dexazone, retinoids, and anti-malaria. So in systematic you give corticosteroids, prednisolone, and then immunocompromised you have azathioprine and cyclosporine. So the prednisolone 20 to 40, which is 3 weeks, 2 to 3 weeks, and azathioprine is 50 to 100, and cyclosporine is 3 to 4. Other you have like dexazone, retinoids, and again anti-malaria.